Jean-Louis Thiaboul.
Okay, thank you very much, Daniel. First of all, I would like to thank the European Society of Intensive Medicine for this invitation to participate in this program. Which are to give practical guidance to most common hemodynamic problems in ICU, onset tachyarrhythmias, low flow states, oliguria despite three challenges, and refractory hypotension. First of all, onset of tachyarrhythmias, and I will concentrate on atrial fibrillation, which is the most frequent arrhythmia observed in the ICU. This is here 168, and it is associated with a low blood pressure and especially a low pulse pressure, meaning a low stroke volume, and we are not surprised by the low stroke volume in this particular situation. So some words about atrial fibrillation, and I will concentrate on new onset atrial fibrillation, AF. Atrial fibrillation and new onset are frequent in ICU patients, including septic patients, and this even without history of atrial fibrillation. This is a recent study looking at ICU population, general population of ICU patients, more than 1,800 patients, and new onset atrial fibrillation was observed in 12% of the population. Recurrent atrial fibrillation was observed in 7%. Recurrent is patient with history of atrial fibrillation and with new episode during the ICU stay. And 81% of patients had no atrial fibrillation at all. There are many precipitating factors which can result in new onset atrial fibrillation. And these factors are well summarized in this recent paper published in Intensive Care Medicine. We have some predisposing factors: older age, history of atrial fibrillation, of course, diabetes, hypertension, etc., obesity, and also precipitating factors. We have condition related, and I would like to insist on electrolyte disturbances, for example, hypokalemia, also hypomagnesemia, and of course, hypovolemia, and sometimes hypervolemia. And in my experience, and probably the experience of many intensivists, hypovolemia is a very important precipitating factor, and correction of hypovolemia sometimes can fix the problem. Shock also and sepsis, infection, but also inflammation are precipitating factors. And we also have some precipitating factors which are related to treatment. For example, the use of vasopressors, and we emphasize on the use of norepinephrine, epinephrine, dopamine, but also inotropes like dobutamine are some precipitating factors leading to new onset of atrial fibrillation. This can occur at any time, and mostly in the first days. For example, this is a study I already talked about, showing that new onset atrial fibrillation generally occurs on the first day, or sometimes the second day or the third day, but not later. This is the same for recurrent atrial fibrillation. It is meaning episodes of atrial fibrillation in patients with chronic atrial fibrillation. Of course, a new onset atrial fibrillation may worsen the hemodynamic condition and essentially resulting in low cardiac output, in a reduction in cardiac output due to the loss of the atrial systole during the left ventricular feeding, but also reduced diastolic time due to tachycardia. And of course, new onset atrial fibrillation is associated with increased risk of stroke, ischemic stroke, due to the clot, which can be moved in the circulation to the brain and increase mortality. And this is a study I spoke about before, showing that mortality was higher in hospital, mortality was higher in patients with new onset atrial fibrillation, 47% here, compared to recurrent atrial fibrillation in patients with history of chronic atrial fibrillation, and also compared to patients with no atrial fibrillation. And when the episode, all the three factors were adjusted, taking into account the co-variables, co-founding factors, still new onset atrial fibrillation was associated with higher mortality compared to no atrial fibrillation or to recurrent atrial fibrillation. So in terms of practical strategy, if we have to distinguish two situations, very poor hemodynamic tolerance and no poor hemodynamic tolerance. In case of very poor hemodynamic tolerance, we should consider electrical cardioversion. In case of no poor hemodynamic tolerance, we have first to try to correct electrolyte disturbances, for example, hypokalemia, hypomagnesemia. And also, we have to test fluid responsiveness and correct potential hypovolemia. And also, we have to consider reducing beta agonist agents and the doses, or replacing these agents by non-adrenergic drugs. If atrial fibrillation persists in spite of these measures, we can have two possibilities. Either to select rhythm control, which is like a pharmacological cardioversion, and we can use either or combination of IV magnesium and this sulfate of magnesium, and this in spite of documented hypomagnesemia and high dose of imiodarone. And of course, we have to check LVF before, because we cannot use a very high dose in patients with a very poor LV contractility. This is a possibility. Another possibility is to have a rate control strategy, not trying to restore sinus rhythm, but to decrease tachycardia, to decrease heart rate. And this can be done by, again, IV magnesium and lower dose, not low dose, but lower dose of imiodarone, and also can be done by beta blockers. Fast half-life beta blocker like esmolol, or maybe landiolol, which is a new one, and there are some new papers about the effects of landiolol on tachyarrhythmias in ICU patients, and especially in patients with sepsis. It is important, I think, to restore sinus rhythm as soon as possible. This is a study showing that in patients with no restoration of sinus rhythm, we have a mortality of 61% compared to 26% in patients with restoration of sinus rhythm. And this compared to 17% in patients with no atrial fibrillation. Of course, we have to think about giving anticoagulation. And this is a debated topic. Of course, we have to prevent ischemic stroke, and this is why anticoagulation is very important. But as you know, we are in the ICU with very severe patients with high risk of bleeding. And so we have to balance the risk of bleeding and the benefit, which can be the prevention of ischemic stroke. And there is no recommendation in ICU patients. This is a study published in the JAMA Cardiology some years ago, and including many patients, more than 38,000 patients with sepsis and atrial fibrillation, and with no alternative indication for anticoagulation. And the authors separated the population in two groups, a group of 24,000 patients, or almost 25,000 patients, who received no anticoagulation, and a group of 13,000 patients who received in IV or subcutaneous anticoagulation. And interestingly, there was no benefit in this study of giving anticoagulation because the risk of bleeding was higher in patients who received anticoagulation compared to patients who did not. But the benefit was not a very obvious reduction of the risk of ischemic stroke, 1.3% in patients who receive anticoagulants, compared to 1.4% who patients who did not receive anticoagulant, and this difference was not significant. So there is no recommendation to systematically give anticoagulants in this situation of new onset atrial fibrillation. What about low flow states? Many things were already said by Professor Price and Professor Vincent, of course. So I will be very quick. And we have, as you know, 4 categories of shock. This is a paper by Jean-Louis Vincent and Daniel de Backer. And distributive shock, hypovolemic shock, cardiogenic shock, obstructive shock. And the majority of shock in ICU patients are distributive and mostly septic shock. But sometimes, of course, we have the other categories, and these other categories are associated with low flow state, low cardiac output. And I think that we can have a very simple decision tree for patients with acute circulatory failure. And here is to try to identify low flow state, because we can, if we identify low flow state, we can have immediately a treatment which is increasing cardiac output. If we have no low flow state in shock, it is more difficult. So how to identify low flow state? By clinical signs, mottling, increased capillary fill time. And it is interesting that if you have mottling and increased capillary fill time, this situation is frequently associated with low cardiac output. This is a study showing measuring cardiac output and looking at the presence of these skin perfusion markers. And as you can observe, the presence of these markers is very specific of low cardiac output. But the absence of these markers is not an indicator of normal or high cardiac output. So the absence of mottling or increased capillary fill time does not exclude low cardiac output. In addition, we can look at pulse pressure, the difference between the systolic and the diastolic pressure. As you know, pulse pressure depends on stroke volume and aortic stiffness. And therefore, a low pulse pressure around 30-40 meters of mercury suggests that the stroke volume is low. So it's very simple to do at the bedside. And just at a glance, you can identify patients with low stroke volume and therefore a low flow state. But a normal or high pulse pressure, more than 40 meters of mercury, does not exclude a low stroke volume in cases of stiff arteries. And this is very frequent in our ICUs. So, mottling, increased capillary fill time, but also low pulse pressure are good indicators of low cardiac output, but also low SCVO2, if you can measure SCVO2 using a central venous line, and low velocity time integral, if you can measure using echocardiography. And low VTI is a marker of low stroke volume. Okay, if you confirm or if you have a high suspicion of low flow state, try to distinguish between hypovolemia and cardiac dysfunction. In favor of hypovolemia, overt fluid losses, of course, clinical context, for example, sepsis at the early phase is always associated with hypovolemia, and positive pleural responsiveness test. So, in presence of this clinical context or test or signs, you have to consider fluid bolus. In favor of cardiac dysfunction, technical context, of course, negative preload responsiveness